All right. Good morning, everyone. Good morning. Thank you. That's what I was waiting for. Welcome to our chosen forum. It's really a pleasure to see all of you. My name is Susan Hwang. I'm a neonatologist here at the Anschutz campus, associate professor of pediatrics, and one of the steering committee members of Chosen Quick. You know, last year was the first time we had gathered in person since COVID, and this time it's the second time. And really, it is so wonderful to see all of you in person and to be able to collaborate and interact face to face. For those of you joining virtually, welcome. We hope that participation can be active for you as well. We're not going to have time to go around and do individual introductions, but I would love for you to just turn around to someone that you do not know, say your name and what group you may or may represent, or some other facts that you find interesting and what brought you to this meeting. For those of you online, please chat in who you are and what group you may be representing. I'm going to give you 1 minute. Please meet someone that you do not know.
So Jane gave you our number so that way we can have somebody else come back over here and give you an so, but yeah, I just took the chat should have been enabled. Okay, so yeah, chats are coming in. Then okay, perfect. Okay.
How do I make this more visible on the
Okay.
screen?
So if you click these three dots over here, and then right here where it says hide floating menu controls,
Yeah.
you click that, and then now click back here on your screen. So that way we can make sure we go through our slides. So now this way it'll actually go through the slides.
Okay,
So
great.
now we're ready to, now it should be absolutely fine. So
Okay.
sorry about the fiasco this morning. So, but you guys are good. What time are you guys transitioning? You said 1 or 2 o'clock? Oh.
So this is our schedule, and so it's really the virtual person is going to be presenting 11:15, and then again at 2:30. So at 11:15, we're going to need some help. But I think, yeah, unfortunately, it's
That's fine. If you want, like maybe at 11 o'clock, just call and let us know that yeah, we're over in the treatment room. We're going to need to do a switch over, and whichever technician is on call, it'll be one of the three of us that you just saw in here. We can run over because all we have to do is stop sharing content here, just like you normally would.
Yeah.
And then when that person's done, you can just go back and share those slides again for the next presenter. So it should be pretty simple. And then same thing at 2:30. It'll probably be me that runs back over to Turkey.
Okay, sounds good. All right. So I hope you all met someone that you did not know before this morning. All right. So we've got quite a packed agenda for you all today. We'll have opening remarks in just a bit, continued by our usual updates given by the three organizations that helped to put this forum on, from Chosen Quick, from CPCQC, and from Illuminate. We will have sharing from Diane Smith, our lived experience expert, followed by a break, then move into our keynotes. The first focused on toxicology testing in our birthing facilities. The second focused on plans of safe care. We'll move towards lunch, and then the afternoon, we'll have three separate presentations that are hospital-based work, our hospital drivers, and then we will conclude the day with a workshop on naloxone distribution and administration. So a lot to learn today. So we're going to transition to our opening remarks. Now, before I welcome Mandy Bakulski, I wanted to share with you two recently released reports as well as an article, and highlighting, I think, some of the values as well as take-home messages that inform our work. In addition, I think are very much along the lines of the perspective that we're taking here in Chosen Quick. So the first was a report that was just published October 2022 by the Biden administration. Has anyone seen this report? Raise your hand if this looks familiar to you all. Okay, maybe some of you all. Yeah, so in some ways, it really was a landmark report focused exclusively on substance use during pregnancy and focused on how we can improve outcomes for families. And so I share this with you so that you are not only aware, but I wanted to emphasize the 5 key values that informed this report, because I think very much this informs the work that we're doing. So the 5 key values are as follows. Having substance use disorder in pregnancy is not by itself child abuse or neglect. Criminalizing substance use in pregnancy is ineffective and harmful. Everyone has the right to effective treatment. Pregnant women with substance use should be encouraged to access support and care systems, and barriers to access should be eliminated where possible. And lastly, improving coordination of public health, criminal justice systems, treatment, and early childhood systems can optimize outcomes and reduce disparities. Now, the administrative plan is also as follows, and all of this will sound very familiar to those of you that are in this room that have been engaged in chosen work. First, improving access to effective treatment, preventing unnecessary foster care placement, supporting families, and keeping families together. Third, making better use of data across services systems to better serve children and families. Finally, fostering public-private partnerships, including hospitals, outpatient clinics, and local communities. And they made a special shout out to state perinatal quality collaboratives in this report. So that's the first. The second is a recently published article. It was published in November 2022 in JAMA Pediatrics and looked at the association of state child abuse policies, mandated reporting policies with prenatal and postpartum care engagement by women with substance use during pregnancy. Now, we have a large body of literature that already has shown us that women with substance use are far less likely to engage in prenatal care. What's unique about this particular study is that this was a cohort of recently mothers who recently delivered a live-born infant, and they all reported substance use. And it really was a comparison of women who lived in states with these type of policies versus those who did not. And so the data source for this was the Pregnancy Risk Assessment Monitoring System, which is a CDC-funded, state-administered perinatal surveillance system. And here in Colorado, it is very robust. And for any of you that are wondering, about trends, changes over time in perinatal outcomes, I really, really highly recommend that you access our PRAMS data system. Now, for this study, this was national PRAMS data that included over 4,000 women with substance use from 23 states. And what they were comparing were women who delivered in a state with a child abuse policy only, meaning if you were pregnant and reported substance use, that was considered child abuse. The second were states that had a mandated reporting policy, that if you were pregnant and reported substance use, that whoever you disclosed that to was considered a mandated reporter and had to file a report with child welfare. The third were those states that had both policies in place, and the last was none of those policies were in place. And this particular study looked at the month of gestation that prenatal care was initiated, the receipt of adequate prenatal care, and then receipt of postpartum care 4 to 6 weeks after delivery. Now, this is a forest plot for those of you that are less familiar with this. The line 0, if you see any result that crosses 0, that means there was no difference between states that didn't have any of those policies and the states that did. Those that are to the right, so those point estimates there, meaning that whatever we're looking at, whatever exposure favors or is associated with later initiation of prenatal care. So here, what we're seeing is that in states where there was child abuse policy or mandated reporting policy or both, women who lived in those states were far more likely to initiate prenatal care later than women who did not live in those states. Moreover, women in those states that had these policies in place were far less likely to receive adequate prenatal care. And then lastly, women who resided in those states with those punitive policies were far less likely to access postpartum care 4 to 6 weeks. And so I'm highlighting this because while we're here thinking about change at the individual system hospital level, we can't forget the policy. We can do a lot at various levels, but what are we doing at the policy level in our state that then allows us to do all of this other work? And so fortunately, we partner with many, many folks who are working in the legislative arena that pushes this work forward. Then I wanted to highlight one recent personal experience that I had. So I was recently contacted by a certain county because there was a sleep-associated infant death in our state. This is always a tragedy. The mother, who was very fatigued, fell asleep with her infant during feeds, and the baby died, unfortunately. And I was being contacted because there was somewhat of an investigation of this particular woman's history as well as the environment in which this infant was found. And so we were told that the mother's toxicology screening was positive, that the home looked like it was in disarray, and there was some concern about neglect. And they were contacting me because they wanted to criminally prosecute this mother for negligence. And so, if we take aside the substance use, the assessment of the home, I think many of us, when we think about a SUID or a sleep associated infant death, we just think it's a tragedy. And how can we best support this family who's going through this? But for this particular family, it was turned into criminal prosecution. Now, I don't know all the details, but what struck me was what happened before this event? What were some of the upstream things that either did or didn't happen for this family that led to this tragic event? The first is, was there substance use screening for this mother and this family, as well as treatment being offered during, before, and after pregnancy? Was there trauma informed mental health support and screening and treatment? We know that nearly 50% of mothers with prenatal substance use have a history of significant mental health conditions as well as trauma and abuse. Third, what sort of maternal infant dyadic health and well-being support existed for this family? And then lastly, what were the roles of child welfare services, various medical providers, and other community organizations in supporting this family? And so for this particular case, there was child welfare already involved with this family's prior children. I don't know the details of what the relationship between childcare with this family was for this current, unfortunately deceased infant. But again, these are the questions that remain. And so today we're gathered to really think about these upstream things. What are the preventative things that we can do to support families so that we are not then facing a really tragic situation distal or further down the line? All right, and now it's really my pleasure to welcome our keynote speaker, Mandy Bakulski, today. Mandy is a public health professional with extensive experience leading and implementing system and policy level changes focused on improving the health of maternal and child populations. In her current role as the Maternal and Infant Wellness Section Manager at CDPHE, she provides public health leadership for state and local initiatives focused on maternal mortality prevention, child fatality prevention, economic mobility, and social emotional well-being. Throughout her time at the department, she supported the development and implementation of public awareness campaigns, expanded referral systems, policy recommendations, clinical guidelines, population-based surveys, and workforce development activities. So we are very thankful that Mandy is here today. Thank you.
Great. Thank you. And thank you for the opportunity to present. I am recognizing, although you all were here maybe a year ago, this is the first time I've stood up in front of maternal infant health colleagues in 3 years. So we're going to shake off a little bit of those nerves this morning. But I wanted to think a little bit as reflecting on the number of years that I've been connected to this topic. Nearly 20 years ago, as I was early in my career and starting into this work, I identified a statement that really described my job. And it wasn't really the what of the day-to-day work. That would be probably really boring some days, but really the why. I am a champion for healthy babies. And to be clear, there is no doubt that to be a champion for healthy babies means we have to center the birthing people and the support systems in this work as well. I'll admit that all these years later, there are days when those words feel pretty far from the work, especially the first title that I wrote down for this was our maternal and child health crisis, right? That the news is heavy, the data are heavy. Last week, I had the opportunity to be in North Carolina for one of our grants with partners from around the US, a number of states who have different policies in place that don't necessarily support the well-being of families and their children. And I was reminded in many, many sessions as people elevated the word joy. And thinking about joy in this birthing experience reminded me of my mantra from many years ago, being a champion for healthy babies. That is a space where you can find joy in the mission. There's possibility in that framing. And I encourage each of you as you go forth today and take the information that you gather today into your next consultation with a client or challenge in a policy space to be champions for healthy babies as well. But I would be remiss to say that we can always center joy and possibility in this work. It is also important to acknowledge that there is heartbreak. So before I share some of the data, I'd like us to just take a moment to honor the lives of the mothers and infants that have been lost with a moment of silence. So I'm going to start by sharing some of our maternal mortality data. As Susan mentioned, the programs at the State Health Department that I oversee are both maternal mortality and child fatality. Those are hard programs to look at the data and see the realities of. So some of that finding joy is also to make sure that we take this and go forward. There were 174 pregnancy-associated deaths between the years of 2016 and 2020. That's our most recent data. A pregnancy-associated death is any death that happened during pregnancy or through that first year postpartum, regardless of cause. So when you look at this slide, this is the causes of pregnancy-associated deaths. You can see there's a multitude of different causes, and pregnancy-associated includes things that are outside of a direct connection to pregnancy. So you may see motor vehicle collisions and cancers that may have not been connected to the pregnancy. But the highlight here is that the top three causes of pregnancy-associated deaths are suicide, unintentional drug overdose, and obstetric complications. When we shift to the pregnancy-related deaths, these are the deaths that have some chain of events that were initiated by the pregnancy or the aggravation of an unrelated condition, but that were exacerbated by the physiologic effects of the pregnancy. During that 5-year period of 2016 to 2020, there were 80 pregnancy-related deaths out of that 174. Unsurprisingly, obstetric complications leads the highest cause of death for those, but maybe more surprisingly, suicide and unintentional drug overdose continue to remain in those top three causes of death. When we look at this data, we also look at the full breadth of behavioral health conditions. So we don't just look at the cause of death, suicide or drug overdose, but also whether mental health or substance use conditions contributed to those deaths. And we know that a large proportion of the pregnancy-associated deaths were from suicide or drug overdose. But we also looked at those that were not due to suicide or drug overdose. So of all deaths, 1 and 2 had mental health or substance use contributing, but even those where suicide or drug overdose was not the primary cause of death, mental health or substance use still contributed to a quarter of those deaths. It's important to note in some of these individual cases, like Susan mentioned, part of the maternal mortality review process is to look through individual cases, and there are a handful where we see that children were removed from their birthing parents at they lost custody at the birth hospitalization due to substance use, and then there was a subsequent suicide or accidental overdose, which really highlights the importance of thinking about safe discharge from hospitals and thinking about the dyadic care, both the infant and the parent in that situation. If custody has been removed, it puts both sides of that dyad at risk. I also want to just acknowledge that while we do see mental health and substance use across all populations, there is a higher proportion of drug overdose and suicide among the white population. There is a racist myth that Black people use substances at a higher rate. They are screened more often and have toxicology tests run more often on them. I know you'll hear more about that later this afternoon, but that is not shown in our data. In fact, Black people are more likely to die from the obstetric complications than the mental health and suicide ones and substance overdose ones. We also know that Black people are less likely to reach out for mental health support because the systems often do result in referrals to child welfare services, and their discomfort and reasons for their distrust are valid. And I shift a little bit to the sudden unexpected infant death and unintentional poisoning and overdose data from our child fatality prevention system. So this is 5 years of data as well, 1 year more recent, so 2017 to 2021. I'll draw your attention to the green line and the brown line on here. You'll see the green line represents sudden unexpected infant death. During that 5-year period, there were 241 deaths. But unintentional poisoning and overdose, there's 77. In that time period, you can see there's a pretty stark increase in those. And certainly while a number of them are driven by our youth substance use crisis as well, we do know that during that time, there were 10 children ages 4 and under who died. So it is not, it's not only a youth challenge. One thing that is not represented in this data, though, that I think is important to recognize is that the child fatality program does not review causes of death that are deemed more natural, like congenital malformations or other perinatal conditions. But certainly, I think we know that substance use during a pregnancy likely contributes to a number of those, and often during that first year of life. When we look at the SUID death, it's almost 11-fold higher than the child, youth, and suicide deaths. We know that it's the third leading cause for infants under the age of 1 in Colorado, the top 2 being the perinatal conditions and congenital malformations. We also know from a disparity standpoint that infants who are living in frontier communities are nearly twice as likely to die from SUID. I think when we look at the policy side of things, it's interesting to see where there are some of the infant safe sleep recommendations aligning with the deaths. So we're tracking that data to see when was something present in that environment that would be in support of the recommendations, or when might it have been absent. So in particular, you can see related to the substance use, smoke exposure was only absent in about 1/3 of those. So a number of the SUID deaths definitely had tobacco smoke present, and then under less than 30% had avoided alcohol and illicit drug use, which aligns with what Susan was saying, that oftentimes that is present as well. So it's not that's not just a simple education, put your baby to sleep on its back. You know, we've got a higher incidence of that happening, but there's a lot in that upstream space that we need to be doing to support families and parents long before they take their baby home. So I just want to transition for a minute to talk about, move from the data and just talk a little bit about the outcomes that we are seeing, moving past the outcomes and moving into the work that we are doing. We have been doing a lot over the past couple months around the recommendations for maternal mortality and child fatalities. Some of you in this room may have participated in some of those recommendations. And what we have gleaned aligns quite nicely with the theme of this conference, a focus on transitions. Transitions matter. They are some of the riskiest moments for new families. That could be a transition from inpatient care for mental health or substance use to outpatient follow-up. It could be the transition from the prenatal period to the postpartum period, in particular, thinking about transitioning families from a hospital to and using safe discharge practices to get them home, or ensuring safe sleep practices are being modeled in the hospital so that when they go home, they are following those same sleep practices. safe sleep practices. We have to pay attention, extra attention to these moments of transition to ensure families are receiving the support, the education, and the referrals that they need to thrive. We have a couple of projects. Not all of these are CDPHE projects. I acknowledge and shout out to the many partners in this room who are leading this work that are happening to try and improve these maternal and infant health outcomes. So I think you're going to get to hear a little bit later about the Moms Plus initiative that's being led by the Colorado Perinatal Care Quality Collaborative, focused on helping parents get the supports they need if they are using substances and transitioning into that outpatient recovery space for treatment with community providers. Knowing that unintentional overdose was driving a leading cause of maternal mortality, we looked at the AIM patient safety bundles, which are a collection of clinical practice recommendations that are intended to improve patient safety and outcomes through the Alliance for Innovation on Maternal Health. We've supported the CPCQC to do the substance use disorder patient safety bundle since 2019, are continuing to support that going forward with some of the funding that we receive both from our CDC maternal mortality prevention work and a new grant that we have, which is the State Maternal Health Innovation Grant. In addition to improving the education to hospitals, we're thinking about the data capacity and how can we use that data to inform better changes in policies and practices. We've also had a focus on workforce development, and we'll continue to have some of that focus as we move forward in our State Maternal Health Innovation Grant, addressing both the co-occurrence of mental health and substance use disorders and increasing comfort levels so that providers can be talking about this topic early and in ways that do not re-traumatize families. So to bring us back to where I started with my thoughts, I pulled up this quote from Tarana Burke, who is known for her advocacy in the Me Too movement. "I'm grounded in joy. I'm not grounded in the trauma anymore. When I see that little hope in people's eyes, when they recognize they're not alone and there are possibilities to move from this place, then it motivates me. There's so much joy packed into the possibility of that." As professionals working to support thriving families and carry them through the often difficult transition to motherhood and parenthood, you can see the hope in their eyes. You can find the spark of joy that will move them from a place of despair to a place of possibility, and you can be a champion for healthy babies. Thank you.
Thank you so much, Mandy. I think Mandy has provided a wonderful foundation based on both qualitative and quantitative data and reports about why we do this work and why we've gathered here today.